The KMT2A menin interaction results in a leukemogenic MACE and HOX gene hyperexpression. And revumenib is a potent inhibitor of this KMT2A menin interaction, and of course results in clinical activity in acute leukemia patients with KMT2A rearrangements or NPM1 mutations or NUP98 rearrangements. So the efficacy was demonstrated in the Augment 101 study, and some of those patients who were responders to revumenib in that study actually proceeded to an allogeneic stem cell transplantation, either first, second, or even third allotransplant. And some of those patients did receive revumenib as maintenance strategy post-allotransplantation. So these were patients who could receive revumenib post-transplant during a study after the protocol amendment. Some of the patients received revumenib via single patient compassionate use protocols. So a total of 16 patients were enrolled. 4 of those patients were from the pediatric setting. The median age of the patients was 39 years old. Revumenib was restarted in an interval between 1.5 and 6 months after an allotransplantation. Almost half of the patients had received a second or third transplantation, and the remaining were after the first allotransplant when they received revumenib. Importantly, the dose of revumenib post-allo as a maintenance strategy was maintained the same as it was during the Augment 101 study for that particular patient. From the 16 patients, 12 patients remained in a CR, and importantly, 6 patients were in MRD negative CR, whereas other patients were not evaluated for MRD. Importantly, we did see patients who had MRD positivity after allotransplantation, but did convert to MRD negative response after restarting revumenib. Another important feature which we did that we had an isolated CNS relapse during revumenib therapy, though the bone marrow remained intact in an MRD negative complete remission. The tolerability of the drug was actually pretty good. So from the 16 patients, only 3 patients did require dose reductions related to toxicity, which was thrombocytopenia and leg pain. And only 1 patient had to stop revumenib as a maintenance strategy due to diarrhea and myelosuppression. Overall, revumenib was tolerated well, and it was a feasible maintenance strategy in those 16 patients. 3 of those 16 patients are actually on revumenib for more than 1 year, and one of the patients is almost for 2 years on revumenib. The toxicity was manageable, and with only few patients requiring dose reductions and only 1 stopping of revumenib due to toxicity.